Gentlemen, let's appreciate them. Let's appreciate them with 111s because it's such a blessing to have them. So put 111s in the chat box just to show some appreciation because they'll help us advance and be well equipped in as far as this conversation is concerned. Yeah, I see people are continuing to stream in, so we're already 16. So for the new people, please introduce yourself in the chat box. And as I said, we are also live on Facebook, so guys can be able to get what we are doing on Facebook. So I want to introduce you to Mwananchi Health Watch Initiative. And the reason why this was started is basically because everyone, I believe everyone desires to live a healthier life. And sometimes maybe getting there can be a bit of a challenge. Yeah. So the reason why we started Mwananchi Health Watch Initiative is for us to motivate, educate, and also engage each and every person on how they can effectively achieve good health, because we all know that a healthier nation is also a prosperous nation, because you can not be able to do anything if your body is not healthy, if your mind is not healthy, you'll not be effective. So at our hearts, the goal was to make sure that everyone can do this in an effective and efficient way. And you can be able to check our programs on our website at mwananchihealthwatch.com. And we'll also be sharing our social media handles in the chat box, so you can look out for that. Yes, thank you guys. I can see you appreciated the speakers. Douglas from Nairobi, karibu sana. Yes, so in this, as the way the conversation will go, we're also going to have time for you to give or to ask the questions. So feel free, the chat box is ours, so we are going to use that. Now, at this point, I think we are going to get started. So remember, we had shared a poster about SHA or SHIF, and we want to get a better understanding on this. So right now, or today, we have around almost a month and something since we were introduced to SHA. And we want to see exactly what does this mean to us as citizens. What are some of the things that we need to do? So today I have my co-moderator, Mr. Elkana Mosoti, who I will hand over this other part to. Mr. Elkana, can you hear me?
Sure. Can you guys hear me?
Yes, we can.
Awesome, awesome. Thanks, Happiness, and good evening to everyone, and welcome to this session. We are glad that you set some time to join, and hopefully you learn something at the end of the day. So we are privileged to have Dr. Mwachonda and Dr. Mailu joining us today to discuss about SHA. And as Happiness said, there's been a lot of, this is the talk in town, and it's important. We thought it's important that we create this platform to discuss and just help everybody understand what SHA is, and just know what to do, just to have that information. I think it's critical as you make your health decisions. You know exactly what it all entails and what you'll be getting yourself into. So without wasting much time, I just want to jump into our questions. But before that, maybe I'll give the panelists a minute just to say hi, and then we'll get started, make sure their mics are working and all that. Dr. Mwashonda, do you mind just greet these wonderful people? You're muted. You're still muted. As Dr. Mwashonda checks the audio, let's have Dr. Mailu.
Yeah, good evening. Oh, it's good afternoon. Good afternoon, everyone. Looking forward to this chat. I hope you guys can hear me well. Yeah, so let's see how we go through this issue of something that I believe is going to shape the discussions on healthcare in Kenya for probably a century or more, unless we call it another name in the coming days.
Awesome. Thanks, Dr. Mailu. Dr. Mwashonda?
Yeah, good afternoon. I hope I am audible now.
Yes.
Okay, thank you. Well, I'm glad to be here to have this discussion today, and I'm looking forward to starting. I think I'm audible enough. Yeah, thank you very much.
Awesome, awesome. So, I think it will be fair to start from the very beginning. As we all know, probably sometime in 2023, there was the conversation was NHIF will not be there any longer, and then there was public participation about a new healthcare insurance, and we saw the Social Health Insurance Act number 16 of 2023, which was enacted in 2023 October, from which we got SHA. So now there's been a lot of confusion about SHA SHIF. So everybody is using those terms interchangeably without understanding what they mean. So I would like to hear from you, Dr. Mwashonda. I know you have really been educating people about SHA and SHIF. Do you want briefly to just help us understand what those terms mean and the laws therein that establish those terms?
Yeah, so I think to begin with, you rightfully said that sometime last year there was a change in law, and the law was basically Parliament passed 4 bills in healthcare that were aimed at changing the health insurance model. Previously, we were under NHIF, which is the National Hospital Insurance Fund. So what happened is these changes in law led to where we are today. So SHA is the Social Health Authority, which is the body or the organization that has been tasked with ensuring that Kenyans have access to healthcare through insurance, the same way NHIF was. Now, in SHA, which is the Social Health Authority, that's the body that's mandated to do that. Now, there are 3 funds that have been set up, and these funds are supposed to be the ones that will then now finance healthcare services for Kenyans. So there's the Social Health Insurance Fund, which is the SHIF. That is why you see this from the discussion of SHIF SHA. Others are calling it SHISHA. Well, so that's the Social Health Insurance Fund. That's the first fund. The other 2 funds under the Social Health Authority, which is the body, is the Emergency Chronic Illnesses Fund. And the third fund is the Primary Healthcare Fund. So what these 3 funds mean is that the body Social Health Authority that then now oversees the 3 funds, the SHIF, the Primary Healthcare Fund, or the PHC Fund, and the Emergency Chronic Illnesses Fund, the ECIF Fund. So the Social Health Insurance Fund is a fund that will require contributions of all Kenyans. And that's for those of us who are salaried, those of us who are in formal employment, it means that they put the contributions at 2.75% of the gross income, which is basically an income tax. And in those in the informal sector, they're supposed to undergo through a means testing and eventually get whatever is computed as the final income. Then 2.75% of that will actually go into contributing into the Social Health Insurance Fund. Primary Healthcare Fund and the Emergency Chronic Illness Fund is supposed to be funded from taxpayers' money. So the taxes that are collected, general taxes that are collected from us, are supposed to cater for these two other funds. I think that should answer and give a clarity on the SHA and the SHIF. Thank you.
Thank you so much for creating that foundation. That SHA is provides an insurance platform, of course, that is financed by both the government and the citizens. Now, with that understanding, let's focus. Go talk about the services themselves in terms of because SHA needs to pay for healthcare services which need to be provided. Now, looking into the services, we know that right now in the country, healthcare is devolved. And something I've been battling to or trying to understand myself is how because we know there are different levels of hospitals, counties in charge of all the levels apart from the referral hospitals. And we know that the budgetary allocation for health, using an example from the 2023-2024, was 141.2 billion. Now, Dr. Mailu, I want you to just give us a perspective. Do you think that the public healthcare facilities at level 2, 3, 4, and 5, do you think they're able to provide services that are promised within SHA? Do you think SHA insurance is able to cover, is able to pay for services which are there? And what would you speak into the services in our public healthcare sector?
So thanks. The first thing that I think we need to define for those who may not understand is the levels of facilities. In Kenya, we have a categorization of healthcare facilities basically done by the Medical Council, formerly called the Medical Practitioners and Dentists. It was changed to a council. And now, basically, those guys are appointed by the Minister for Health. Previously, would vote for representatives besides the government appointees. And so they have a criteria, and it is available in the council's page that will be able to let the people know what that means. As well, I think SHA has linked the different lists on their website for people to be able to tell what is which facilities under what. Besides that categorization of healthcare in level 1 to 6, and public facilities. Now, the private facilities, some are called semi-private, which will be the faith-based organization or charitable hospitals that you may find. Mostly some mission hospitals, the ones that are run by either groups of church, Hindu or Islamic groups that start them. Level 1 of healthcare is basically community. And that's where you've seen a major emphasis on community health promoters, community health volunteers, so that the family and the community by itself is supposed to provide a very basic level of entry and information to people. Level 2 is what we used to call dispensaries. And this is where the government facilities tend to begin. Level 3 are health centers, priced into almost 3 of issue they have and the bed capacity and whether there have been any inpatients and testing capacities. So the very basic ones that have no X-rays and others are level 3A, and the more complex ones will be level 3C. And then from there, the basic hospital that you'll find, what we commonly call a sub-county hospital. Those are the level 4 hospitals. And they have some equipment or the emergency obstetric care service. So they have a basic theater, they can deal with a mother in labor who needs an emergencies, yes. They can do better surgical interventions, and those are level 4. So most of the hospitals in our public health system would fall into that category. We are then level 5 hospitals. These are the ones that are able to offer specialist care. And that's where you find a lot of the county referral hospital advanced private facilities. They are very advanced, highly complex service hospitals, those that we call level 6, such as Moi referral, Kenyatta National Hospital, KU referral, those ones fall within that category. Because in the private sector, you can think of their matter to offer this service. My answer is actually yes, because in terms of a lot of human resource for health, which Machonda can speak to better than myself, a lot of those facilities have some level of competence in terms of healthcare workers. If you look in terms of finance and equipment, that's where the biggest question comes in. Fortunately, once healthcare was devolved, the financing has been a mess. There's no ring-fence financing as was done in the Kibaki days for those facilities, and therefore each county executive chooses on it. And that may be the biggest thing that Kenyans need to demand of social health insurance. We're supposed to provide the primary health care. Usually people improve on the primary health, and then you go more to the advanced healthcare. So the biggest question is usually funding, drugs, and the equipment, and then ensuring that there's consistency of the human resource. The bigger issue I am seeing is that a lot of counties are putting people on short-term contracts. I think there was a big case the other day on some of those things in courts, and they were healthcare workers actually. But the bigger issue has been, can these people stay on? And increasingly, sometimes instead of, so for example, a good health center should be managed at least by a medical officer. A level 3C, in my view, should be managed by a family physician. And if that was done, that would be the case. But if you go to most counties, they would rather fire those guys, hire the lowest cadres, and then say, we have brought healthcare close to you. So that's a point to which it is thing. Now, SHA itself, if you look at what they are allocating for some of those services, I am also sure that that level of funding and payment by SHA through the SHIF, because so far they have only operationalized the social health insurance fund for common conditions. They have not operationalized the emergency and chronic diseases. They are yet to operationalize the primary healthcare fund. So I am also sure whether what they are proposing to offer to those facilities can work. For example, I think what I have seen being discussed is 900 shillings. And if you capitate either by 900 or you say 900 per visit, if you go to a nurse in a level 3 hospital that has an x-ray and she tells you, okay, we are going to do an x-ray, that's already 500 shillings. So what remains for consultation, what remains for medication, and that is government. Yes, so that's actually the bigger thing. So if facilities can offer the care, they need to be equipped, they need to be funded. And that's where capitation by both SHA and the national government has to be done. It cannot be left to the county governments to do that.
Thank you, Dr. Mailu, and you bring out a very important key point in terms of understanding, in terms of management, and I think you can have all the resources, but if there is no clear management, then they will not be useful. And also the concept right now, as you indicate, SHA has the primary aspect of things, which generally, even when you look at the country, I think there is a lot of awareness that needs to be created towards promotive and preventive care. Because I think what we've seen is that most of our people usually wait until they are extremely sick to seek for healthcare services. I'll come back to you because we need to understand the referral system and how that works, because I think most people who are joining us here and those who are watching us for live on Facebook, by the way, if you have any question, you can just put it on the chat here, and on Facebook, just do a message, and one of our team members would let us know about what questions you have. So most of the people attending quite young and young people who take care of their parents, and it's important they have a good understanding of how these systems work, so then they're able to provide that good support to their families and parents back in the up country. So speaking of that, I want us to talk about the means testing tool that SHA is using, and of course the tariffs and the benefits, because as we know, SHA is mandated by, right now it's mandated legally. Every Kenyan should be registered in SHA, and of course also there is a requirement for contribution. We know that through statutory deduction, or those who are in formal employment, they are deducted 2.75. And then right now, the statistic I got is that only 20 million people, approximately 20 million people in Kenya are employed, but only 3.3 are in the formal sector. 16.7 are in the informal sector, the mama mboga, boda boda guys, and those who have their own self-employed businesses. And and this means testing tool is targeting the informal sector. Dr. Mwashonda, do you want to speak into that? What do you think? Do you think that there's been a lot of fears in terms of exclusion era, where those poor people also asked to pay? Others have been asked to pay extreme premiums, which is not in tandem with what they make in terms of income.
Yeah, I think, thank you for that. And I think one of the biggest challenges this was going to face was the informal sector in terms of earnings and in terms of coming up with premiums. So the means testing tool looks at so many other things. It has several questions that once you register on the portal or you dial *147, you're required to actually fill these questions. They look at the type of house you have, things that you own. Then they also look at the number of family members. Then they also go and look at your transactions, mobile money transactions. I think that's one of the things that really came out of that. And then eventually now there's a score that is given from that, and that score is then what is used to determine your premium. I came across a story of a lady who, and once you register, once you fill all these questions, it doesn't mean you get your premium at that point. So you've registered, but then you have to go to the offices, the SHA offices, and now get your premium. You pay your premium, and then now you can access services. So there's a story of a lady whose premium came to, and the premium, by the way, is paid monthly according to the Social Health Authority Act. The Act, it's not monthly premium. So if let's say for the lowest, if it's 300 shillings, you've been determined that you fall among those who are indigent and maybe require support, it will be required 300 shillings. That will be 3,600 times 12 months. So the story of this one is that she got a premium of 84,000, which was a premium of around 7,000 per month. And this is a lady who works, who is in self-employment, but the transactions showed a picture where because she's a treasurer in one of these chamas of women, and so that is what the premium was calculated as. And so she was appealing and saying, I do not have 84,000, I can't pay that. But then your means testing has shown something else, and then means you have to appeal that. So this became a barrier, because at that point, then this person is being asked to pay for 1 year, they do not have this amount of money. Now imagine a case where, those in the informal sector that cannot really compute their earnings because they don't do it. There are people in this country, that's the majority of people, who live on a day-to-day basis. What they get today is what they spend, and then tomorrow they wake up, they go look for a job. The casual workers look for a job, get some money, and then continue with life like that. So they take care of very basic things: food and housing, that is shelter, and maybe a few basic items. And that's where the challenge is going to be in terms of administering this tool to the majority of Kenyans who are in the informal sector. I think I have answered the question. If there's any part I've left out, maybe you could just tell me.
Yeah. I'm so curious because I think this is also very important to follow up. So if SHA determines, of course, using the testing tool, if they determine the premium, are you able to appeal? And how does that process look like? Because definitely, if they're using like the mobile transactions, all these income indicators, most of them will not be accurate. For example, if someone's mom in up country, if they send them money, this can be an indicator that they are, maybe I'm sending money for my own project to my mom. It's not her own income. So if then she's given a premium of 7,000, that's not accurate. So is there an appeal process, and how does that look like?
Well, there is an appeal process according to what is on the website and on the portal. You appeal and then you set your case. But you can imagine the entire system is not yet functional. It's been very dysfunctional since the onset. That was on the 1st of October. So there are delays currently as we speak. And so there's an appeal process in which they'll have to determine, you'll have to state your case. And I like the fact that you've used the case of sending money to your mother. I think those of us who have parents who've retired, in fact, those parents who've retired will tell you that when they try to register, what happens is there's no option for retirees, so they have to register as self-employed. So that means whatever amount of income or maybe assets that they own are going to be used now to score and now give them a premium. But there's an important point you say that as if a parent is retired, the children send them money frequently for whatever reason. They're the ones who are then financing this matter. So you're financing yourself, and then now you're putting the young Kenyans in a position where they also have to finance for their parents. And I think that's a very big obstacle and hindrance to even access these services. So that's the challenge that is there. But the appeal process is there. In regards to whether the appeal process can go through without you having to pull any strings or without you going and camping at these offices, I'm not so sure about that. I've not been able to have any account of an appeal process so far.
Thank you for responding to that. Coming back to you, Dr. Mailu. Now, people are paying a lot of money. And from also the little information I've gathered, for SHA to pay for you in levels, I believe 5 and 6, you have to be referred. It's based on a referral system. So can you talk to us about that process? Do we have an established system in Kenya, a referral system where it's authentic that someone can be referred and get services without a problem or without being asked to wait for 1 year or 2 years?
Now, this is where dealing with government sometimes is a bit of an issue. Yes. So what you find is this is a matter of a quick history. You know, the whole process of trying to get a universal health service into Kenyans is not a very new thing. I guess many people here may be very young, but I think it was either 2005 or 2004. There's a lady who was called Charity Ngilu. And then I think after her, during the coalition government, there was Professor Nyong'o. And together with a lot of guys wanted to get a universal health system where no Kenyan goes without healthcare in place. And I think if you've listened to Machonda and others when they have led the KMPDU, you said we do not want poor healthcare for poor Kenyans. We want equitable quality healthcare for every Kenyan. Because what happens is the minute those guys cannot access healthcare, mimi na daktari na wewe, sisi ndio tunachangia. The same thing now we are saying, that we typically have to pay for our people. So what happened is universal health was actually supposed to have kicked in just before COVID happened. And when COVID happened, this is the first time the government was a little more organized. When COVID happened, then the donors who usually fund some of these things and the ministry itself started to put in some things in place, hopefully, so that by the end, unfortunately, as usual, some people ate that money and has frustrated the system. Then we love politics as Kenyans. The Social Health Act was drafted before. It was tabled several, pulled back, and eventually it came through last year, which is a big plus for us. And so that's why I was saying this is gonna be with us for a period of time. And this is the way to go. The whole concept, if you look at it, seems to have picked the idea.
Sorry, Dr. Mailu, you're breaking up a little bit.
Maybe he can switch off his video.
Oh, yes, yes.
Or
Dr.
should I?
Milo, maybe you can try to switch off video so maybe the bandwidth would allow the audio.
Should I switch and use my phone? I will also switch to my phone, to my phone network. I think it's going to be much better. So that has been the catch, because the bigger problem has been the rollout. The people, there's a chaos that was created in the rollout. The testing for this cover to started late last. Initially, we were rolling out the system by January, and it was pushed to June, and then September, and then October. And if you look at the initial testing of how the system was to work, it actually failed in testing, I think, in counties. And so that's where you're finding the chaos that is in there. Unfortunately, having some background information, I think the biggest problem was running into a new system where there was a stable. Remember, it was SHA is actually a mutation of NHIF. It's not a totally new entity, but we reformed what would have been NHIF would look like. So it's supposed to have merged seamlessly into that. And unfortunately, in the process of migration, the IT system, for whatever reason, they sort of abandoned it for some time. And therefore, there was no program. That's why you're seeing the mess that we have. And then there was no proper onboarding of Kenyans. What do I pay? Who pays what? That mean testing, which is supposed to have been completed before onboarding of people came into place. And so, yes, it's very costly for salaried Kenyans, and I think salaried Kenyans are carrying, and not just salaried Kenyans, the Kenyans in formal sector, because those who has a thriving practice, KRA already has their income, so they're what you're gonna pay. Is those that can pay are now carrying a disproportionate example of the 5% we are told that
Seems we lost you again.
Let me get on this.
Okay. We'll come back to.
Eric, you're muted.
Sorry, we'll come back to
Okay.
Dr. Mailu. We'll come back to Dr. Mailu. He's talking about a very important aspect. So we'll come back to him. I'll come back to you, Dr. Mwashonda, about sustainability. You have interacted with patients, with many people, even in the digital space. And just to give a perspective in terms of looking about the financial projections of SHA, because the sustainability, as we said, the first aspect is governance. Definitely governance is the big thing. And then the resources that are available to sustain this new ship. So we know that until now, the government has only allocated 6.1 billion to SHA, and that has been divided to the primary care fund and the critical and chronic illness fund. And then we know that there's the Safaricom consortium that which is now a loan to SHA, 104 billion. Already, the struggle for NHIF was debt. And even SHA is still dealing with the evils of NHIF. I think as of last week, the debt stood at 19 billion, the debt they inherited from NHIF. So from what I saw, the SHA's projection or their budget, their annual budget is 168 billion. And they hope to, a very big hope, to collect 148 billion through SHIF. Do you think, looking at those numbers, I know you've interacted with that and you know how NHIF used to operate. Do you think that this budget, the budget projection and how the finances at play here, do you think is this realistic and is this sustainable in the long run?
Yeah, I think, thank you for that. I think that gives us a very good perspective. If you remember during the budget making process, the Ministry of Health went to Parliament, the Parliament Budget Committee. The projections and what they had requesting for at the time was almost 100 billion for the two funds, that's the primary healthcare fund and emergency chronic illnesses fund. And that budget was really slashed. Going by what was put out in the media, it was slashed to almost 4 billion from 100 billion. The whole point here is you asked about sustainability, and you don't have to go far to give an answer to that. For the last 10 years, the country has been under a devolved system of governance where we have the county governments and the national government. And we see how counties have struggled to get funds from the national government. Up until now, as you speak, there's still a dispute in regards to how much the counties should get from the national government. There's that 20 billion, I think, deficit that counties are demanding for. The national government is saying we've had enough. And we've seen counties go through challenges in accessing of funds from the national government. I think disbursements can lag behind by almost 3, 4 to up to 6 months in the worst case of scenarios. And given that PHC fund and the emergency chronic illnesses fund are going to be drawn from the exchequer, that is the first thing I foresee as a challenge in terms of sustainability. That the country has a debt that is servicing. And then when it comes to healthcare services, these two funds are supposed to be drawn from the exchequer. And if counties that are in charge of not just healthcare, in charge of agriculture, in terms of governance and all other, their administrative units and governments in their own right as semi-autonomous, in the country, can have this challenge of disbursement of funds. What about healthcare? We've seen it in the education sector, where the education system has had challenges also with disbursement of funds to schools. And so we're not going to see any different picture. The reality is that you're going to see the same picture playing out. But the worst thing here is that when it comes to healthcare, it doesn't have that luxury of luxury, sorry, doesn't have the luxury of time that we can wait for disbursements. When someone is sick, then in healthcare, it is immediate, it is emergency, it is an emergency, it has to be sorted and funds are supposed to be availed. And that's going to be the biggest point for me if, from a sustainability perspective. I don't even want to go into the budgets in terms of how much was allocated, how much was projected, because already what has been allocated and what had been projected, if you look at the Ministry of Health website, it talks of 168 billion total and 6.1 being 6.1 billion being given out for this rollout, or even for the starting point. Already tells you that that's less than 10% of the total budget that they had projected. And that's going to be a big challenge already. If at the point of starting, the amount of money you're supposed to put in is already less than 10%, what makes you think you're going to achieve this in the next 5-10 years? I mean, it's almost impossible given the history we have as a country when it comes to funding public programs. I think that answers your question.
And thank you for setting that that perspective, and it's important that everybody knows the realistic, truth about how the future looks like. And I'm not sure if Dr. Milo is. Oh yeah, he's back. Just to continue from where you left, do you think this is more of a political problem, or it's because from my eyes, I see it as a political problem where it's a whole issue of what regime takes over and what policies they are pushing. And then the concept of course, as you are saying, as you're building, I liked the context you're building from how things have changed and based on the regime that is there. So I want you to continue from where you left and even talk to, does Mwananchi get value for money when they're contributing to SHA and the healthcare system?
Yeah, so that's where I was coming to, and I was saying I think one of the biggest problems in terms of the value for money comes at the collapse of NHIF system without having a proper platform for transfer of people. Because if you had asked me, and if I had sat in the shoes of someone who is keen to run a healthcare system, what the law should have provided is a complete rollover of the NHIF contributors, as it were, straight into SHA. And that is there. Of course, there's the data protection issues, but I think that is neither here nor there in our setting. So if you look, for example, at the person who is earning, say, 1 million, 2.75% being contributed by that person is how much? you know, that person will be contributing, is it 30,000? Or something like,
yeah, 27,500, yeah.
It's 27,500. If you just round it off to something like 350,000 a year, it will be somewhere between 300 and 350,000 a year. I can tell you, with my eyes closed, with that amount, you can buy a cover for a family of 5 that is equal to the senior most covers. I mean, the covers of the senior most UN employees. Tell me that person is going to get the value for his money. Of course, a social insurance system doesn't look at that. It looks at being able to provide certain essential care to the whole country. But the problem comes that there will be this disproportionate burden to those who are already heavily taxed. So that if you add the housing scheme, if you add the SHA together with all the payee, probably now Kenyans are the most heavily taxed. And these people, if the SHA was able to provide a certain quality of care, even in whichever hospital for that person paying that amount, it will be okay. But then principles of equity demand that those who cannot pay are supported a bit by those who can pay. However, there is no balance in delivery for that. And basically, I'm just saying it will probably be quite some time before we can see proper value for money for those who are contributing, and those, even some of us who are paying for their parents. So it will be quite some time now. The political aspects of changing things is a hard thing and the reality of Kenyan life, because typically nations, countries do not die, and neither do governments die. What dies and comes to an end are administrations. I know Kenyans are used to an administration and a government is one and the same thing to Kenyans, but that's simply speaking, that's not what happens. When president retires or is fired in an election, the government continues and the country continues, and this goes into perpetuity. So if we were very keen on institutions, we would build these institutions in a way that we actually end up in a place where within 5 to 6 years, it's possible for the 3 funds to roll out and cover our care well. But our government has also not been funding healthcare much. Besides the tax allocations, about 120 to 180 billion of money comes into Kenya from donors to fund our healthcare. And that's why we're struggling. Sometimes, like, I'm also sure now with Trump, what is going to happen with HIV programs, because I think he's likely to wind up the PEPFAR program. It's the same thing. If you look at it, they will tell you 57% of our healthcare spending is out of pocket. And you're more likely to drop back to poverty if you get sick. So there are a bit of those realities when it comes to the funding and the balancing. But I guess for me, what I'll tell Kenyans is we need to demand better. We should not demand that we should never dismantle SHA. We need to have a healthcare system that works for all. What we need to demand is better governance, accountability, efficiency, and simple processes. You see, like my grandmother and everyone else's grandmother, most of our grandmother cannot be able to read the things that SHA has put in English on our website. Can they? But if you actually look at these processes, nobody has bothered to put them in proper Kiswahili. Nobody has bothered to put them in pamphlet. We should be having some education that is very clear in our local languages, because we want everybody on board. And if we do that, slowly we will push these things. I actually believe we can collect close to 200 billion for healthcare through these funds.
Yeah, and that's very true. What you're saying is it's very true. It's at the end of the day, it's more of a political challenge that we are looking at, and hopefully, as you're saying, that Mwananchi will be able to demand for value for money, because this is your taxes. This is the money that you contribute towards healthcare. And interesting, I was looking at those statistics. The donor fund, like Kenya relies heavily on donor fund for most of the healthcare programs, especially through the national government. And that one, just I didn't know how to think of where then does the budgetary allocation go to, because if a huge a significant portion of the programs is funded by donor fund, then there's a question of how are the other funds used. Ben did ask a question there. We'll get back to you, Ben. I know Dr. Moshonda has to go to another meeting, but I want to, before you go, I want to hear from you about public trust and buy-in. And also, of course, in terms of public engagement. Do you know, do you think that we have, of course, we have seen a lot of hashtags from reject SHIF, SHIF is a scam, and even the cabinet secretary, when she appeared, Dr. Baraza, when she appeared on the Senate, she really struggled to answer the questions around how they are going to collect the premiums from the informal sector. What do you think went wrong in terms of public participation, in terms of public buy-in? Dr. Moshanda?
Yeah. So the first thing is that there was not adequate public participation. I think this came out in the court judgment that was given before that had actually stopped the rollout of this. So there was no adequate public participation. But the other thing is that there's been very poor communication to Kenyans. I think that is clear. For anyone who has followed this up, if you ask normal Kenyans, what do you know about SHIF? What do you know about SHA? What do you know about the money is supposed to pay? I mean, people don't understand, and there's been very poor communication, and that has started from the start up until even this rollout that has been done. I have had an opportunity to have a sit down with some of the community health promoters and ask them about the challenges they are facing when they're registering Kenyans. And a good number of them are telling me Kenyans just don't want to register. They believe it's a scam, it's a fraud, and so they don't want to register. So if you look at the statistics that were released this week in regards to registration per county, I don't think it's a county that has gone into almost 50%, none, 20, 30% in most of the counties. And I think that's where the challenge is. That one, the design of this, and that's the last point that I wanted to put across to answer your question, was the experience of Kenyans when they seek healthcare services. So fine, you've rolled out a new social health insurance scheme starting on the 1st of October. It's 45 days now. But what is the experience of Kenyans? They go to healthcare facilities, they have to pay for treatment. Now, the fact that there was this change, major shift of how you should seek healthcare, you can't just walk into a level 4 facility, which is what most Kenyans have done over the years, I mean, for years and decades, is you have to go to a primary level healthcare facility, which means that they've designated these to dispensaries and health centers, level 2 and 3. You go get a referral, and that's where the other challenge, which Dr. Mailu actually has addressed, is the referral system. It's inexistent. You don't have a robust and proper referral system. And so all this now, coupled the experience, the poor communication, and then the rollout that has been done in a very chaotic manner, actually, for me, it validates the feelings of Kenyans that this thing is a scam. Very few can attest to positive experiences with the system and with the way it has been rolled out and the current funding model. So I think I will not say that they're not justified. I believe they're justified based on their experiences so far, which is the majority of experiences in terms of when they are seeking healthcare. At their time of need, they do not need all this confusion and distress that they've had to go through. Thank you.
Yes. So what would be then the way forward for Mwananchi, for all the families represented here and online on Facebook? What do you think, what encouragement would you give them in terms of what is like the way forward?
I think this is where we need to become active citizens in terms of participation, in terms of actually voicing out in terms of putting the government and asking for government to be responsible enough to take care of all that. Much higher level, there's no harm in the government just putting brakes on this system, just rolling back and allow people to use the previous NHIF, rethink the whole thing, undertake adequate public participation, and then now out in phases. I think South Africa has passed Model Act, Universal Healthcare Act, sometime in May, but they're going to roll it out over the next 4 years up until 2028. And that's a good example for me, where you try bits and pieces. Let's see how primary healthcare is, so that Kenyans start to understand that moving forward, you'll need to access outpatient services from a healthcare, equip the hospitals. But then the Kenya Facility Health Sciences report by the Ministry of Health shows a very dark picture of healthcare facilities in the country. So to me, that's very important, that it's not too late to actually take a step back, put brakes, reevaluate the whole thing again. I think 45 days is enough to actually, but if we insist this is working at the expense of lives of Kenyans, I don't think it's going to help us in any way. Thank you.
Thank you so much, Dr. Mwashonda, and we are so glad that you had time to speak to us. Please follow Dr. Mwashonda on X, and then also he's on TikTok, and he has amazing information. If you want to learn more about healthcare policies and what is going on in the healthcare space, make sure to follow him to learn more. Thank you so much. We appreciate your time that you set to join us and also talk about SHA.
Thank you very much. I appreciate and keep up the good work. We need to expand the audience more, get to more Kenyans to understand what is happening. Thank you very much, and all the best.
Asante sana. Now back to you, Dr. Mailu. Talk to us about, I'll ask you the same thing, about public trust. And of course, this is also in line with the healthcare services that we get when you go to a hospital. How do you gauge the public trust?
The reality is that public trust is not a common thing in Kenya. One man told me the reason is because honesty is very rare in our setting. And usually, if we are dealing with people who do not already trust government, remember the process from last year to this, even before the SHA itself became a reality, there had been other underlying governance issues. And so it's just those kind of public things that come in. And our government this time around has been very poor of communication. That is either by design or by default. Typically, people are not very good in managing public resources, love confusion. And they also like half-truths. It's usually by design, because when you can't tell what is the truth from the lie, things just go and people get accustomed to things just being that way. So even if things are being robbed, even if things are being taken off, that could happen. So it could be that what we consider chaotic rollout of SHA is employed by some people so that by the time the system is good enough, there's loss of enough revenue and other things. So that may be one of the reasons. But the second thing is Kenyans do not pay attention to details that matter. Generally, as a population, we tend to pay attention to political maneuvers than this, because SHA is actually our life. So if a lot of guys had paid full attention to it, then there would be a better progress. So the whole thing about public trust is multifaceted, and I don't think governments world over are that trusted by people. But for countries that have run these things and run them well, even where there is a problem, so like there's a time in the UK they had proposed that the National Health Trust would be broken into something. My friend, politicians were sent home, and things were trending, hands off our NHS. It was a very, very serious thing, because for them, that's a lifeline. And it really makes life affordable for many people when you don't have to think about it. As my colleague said, the standards of care in public facilities, because of lack of equipment and drugs, and healthcare is not buildings, as many governors want to do. Healthcare is actually, do you have the correct personnel? That's the number one thing. And number two, do you have the supplies that are needed to deliver this year? Ukiwa na hizo vitu, hata kama uko kwa Kadhigira, you will be okay. If you have a doctor, even if they're in what kind of a building, as long as it's clean inside, you will have some quality care. I'm not saying we shouldn't do the buildings, I'm saying the order of priority is a bit different. And so that's where you are seeing a lot of these things and trust eroding. And politicians are very good in coming out and telling you, oh, you know, SHA and SHIF is rolling out. I mean, the Rural Private Health Facilities Association did its quick study among facilities to figure out. And I can tell you not more than 10% of the facilities have seen any payment in the last 45 days. So if someone has spent money on you, they have bought equipment, they have paid doctors, and the very government that owes them doesn't pay them, how will services improve? So those are some of the big issues. And I told someone early in January, I was actually considering the move to SHIF to be one of the biggest risks in terms of financial risks to health facilities in this country, because we are just very good in creating chaos as Kenyans, despite having adequate time to roll out things and people who know what to do. So, for example, NHIF had very, very good workers. Within 24 hours to the rollout of SHA, I was talking to someone and he told me, we are jobless. We don't know what our role is. We don't know where to go. We are not even sure that we still belong to NHIF or SHA. So what did you expect of that? So Kenyans really had a right, they have a right to feel aggrieved and to feel that they cannot trust the government. But I think what we need to do, as I've said before, we need to push harder, we need to demand better services, and we need SHA to work. We should not go back. It has bolted, let's make it work. And that can only come by demand. And that demand, part of it is you guys writing to your MPs. When they show up, mkiwasalimia, msiwasalimia tu kuhusu siasa na Gachagua. That is neither here nor there. These are the things now we should be greeting them about. Mnawapelekea hizo bill zote za hospitali, mnasema hamjaunda SHA vizuri hapa. You go to the governor, you say you're responsible for our healthcare, pay for us because this is not working. Because remember, the governors are part of the board of SHA. They are represented. And the county health executives for health.
Yeah. I think when you look at, as you're saying, in paper, SHA is amazing. When you look at everything, all the written documents, everything how it's presented in terms of in paper, it's an amazing thing for Mwananchi. But of course, now when you bring that into the reality on the ground, mambo iko tofauti. Yeah. So before
It's just
us,
government inefficiency or by design, because the truth is NHIF staff and management are prepared for a smooth rollout. There was no emergency in creating a new website. In any case, those people in IT here would tell you there are things called API integrations, and there's something called phased move into systems. So they would have easily logged on. All they needed to do, KCB has changed logos and things how many times and acquired other banks. You've seen Access Bank acquire banks. You've seen EcoBank come and acquire other banks. I don't think you ever had the people with money there say, oh, I could not access my money because they were changing the system. Have you ever heard of us? There's a way to do it. And just the same way, if you drive by community now, you'll see SHA building, the way they change the logo. All they needed to do initially is just change the logo in the system and use the NHIF system as a roll on and have the new guys from Safaricom and wherever other group are to create a new system. We would not have had this chaos we see. It's a no-brainer really for me.
I do agree for sure. And yeah, if we all stand and say politics out of our healthcare, I think that would change a lot. And before I ask you now about what is the way forward for Mwananchi, I would invite Happiness to read a few questions, and then we can talk about those, and then we'll be done here in 10 minutes.
Thank you, Eric, and thank you, Dr. Mailu. Truly, you're shedding a lot of light for us. So I read the first question from Benson Mwilu. Why are the changes so different from the former cover NHIF? Like, why are the changes so different from the former cover NHIF? And he's gone ahead to give a real life example. So he says, after the process of registration and logging in, I was told my contribution will be Kenya shillings. I can't see this well. 1,030 monthly. Kindly help me understand. And will this amount increase after adding my wife and children? So the main question there is, why are the changes so different from NHIF?
So the initial design of SHA was such that every person would contribute, anyone above 18, that is, and the children will be covered by their parents. And so that's where the problem is. If you look at the former regime, for children, there was the Eduafia. For pregnant women, there was Linda Mama. And these are some of the things that could be easily matched to provide care. So the big problem that has come is the means testing. It's the reason people are finding themselves with the different charges. Because for those who are voluntary contributors, the system has been set to auto-calculate your contribution based on a few factors that they have found, either by information you provide or what the government has in their records as showing your financial capability. So that's where there is going to be a little bit of some things. I said some actuaries and health financing experts were involved in it. But once you start off, you will have to appeal for that to change. That's the hardest part of this. Yes, that's the hardest part of it, that you would have to actually appeal. Otherwise, that remains your monthly charge for a period of time.
Thank you, Dr. Mailu. I hope, Benson, you've been answered. So there is another question from Paul. So what happens to contributions made through NHIF? Will they be moved to SHIF?
I assume that comes out of the fact that there are some people who had prepaid. Maybe you paid in January for NHIF as a whole to the end of the year. So those charges, once you register in Afya Yangu, there's a platform that SHA has put in place called Afya Yangu. It looks a little bit more or less like the former NHIF system, but it has been tweaked a bit. Once you log in to that system and you register, that the amounts you had prepaid to NHIF before are carried forward. The few people who have helped to do that, that's how it's happening. But it is not, what would I say, it's not trouble-free. There are still some people finding issues with it. But if you had paid before you register and you find your balances are not reflecting, just go to the nearest SHA office, they'll update that for you. It's not, pesa yako haifai kunywa maji.
Thank you, Daktari, for that. So there's a question from Mercy. Can we clarify the issue of SHA tariffs? So I believe this had been tackled, but maybe, Daktari, you could also put insight a bit.
I'm also sure that the SHA tariffs they're talking about is the ones that the individuals are supposed to pay, or they're talking about the tariffs as relates to what you can be given and the restrictions that are given for different services. Because
Mercy,
they're
yeah.
two different things. If you look at what they were circulating even to different professional associations and interest groups in healthcare space from last year, there's those tariffs. And basically the bare minimum, if it's in terms of payment, is supposed to be 300 shillings. And then for everyone who is capable, they are assessed at 2.75% of your employment income, or your gross income if you have verifiable sources of income. So that's the payment. And once it's put at that 2.75% per annum, it's then split for you to pay. over 12 months. Now, there are the other tariffs, which is basically what NHIF is saying, not NHIF, SHA, SHIF is saying, we are going to pay this for this kind of service. So, for example, I think they're indicating for diabetic patients in a visit, I don't know how many visits they will give in a year, they will be able to pay 4,300 to your provider. If it's an MRI scan, I think they're saying they'll pay 11,000. Things like those. For injuries, the people are getting surgeries for orthopedic, for trauma from road accident, orthopedic surgery. That's about 136. It's gone down from what the other groups were giving, total joints. And there's actually an available, I could send a proposed thing. It's actually available on both the kenyalaw.org as a subsidiary legislation. And it's also available on the SHA website for those ones. They have defined the things. It's just that there are very many, because healthcare, there are so many conditions human beings deal with that you're probably looking at very, very many items. And being technical, many people may not be able to pick out what are their benefits. So I don't know, there's a tariffs and then there's a benefits that will be offered. And that's what people need to know well. Because even in terms of surgeries, they define how many emergency surgeries can a family get, how many major surgeries, and how many specialized surgeries, and what different tests are there. So yes, those are available, and those are the things I was saying. The government has really failed in educating Kenyans what is in there. And it's what we saw as I finished the last few years, where people would come and say, why are civil servants being paid for everything? And as we are being told, we can only get 9,800 for a CT scan. Those were two different schemes. The civil servants had their own private medical scheme, which was called the Civil Service Scheme. It was previously managed by NHIF, but it will probably now go to a commercial insurance, the same way many corporates do. And then there was a regular NHIF, which they also deducted. So those are different kind of things. People need to know, what are the benefits I get from this? If you buy data bundles from Safaricom, they'll tell you these are the bundles you get for 500 shillings. They expire or they don't expire. You can share, you can't share. It's the same thing with healthcare. When you pay for SHIF, there are certain benefits, and then there are the obligations.
Thank you,
I'm not
Dr.
sure if you
Mailu.
finished answering all questions.
Yes, you have clarified well, and I have put the websites that you have pointed to, so that anybody who wants to get further details can do that. Yeah, so those are all the questions that we have here. But if you have more, you could still put them here or ask on our website. We will be happy to answer. Yes, thank you. Over to you, Eric.
Thanks, Happiness. And yeah, so I know you might have already covered this, but Dr. Mailu, what do you think is the way forward for Mwananchi? What would you tell these families represented here?
I wish I had the ability to influence the Gen Zs again. What I'm saying is that if you look at our social media, I think the other day X gave their statistics for countries that use X massively in the world. And surprise, Kenya was on top. I think 3-point-something million. What we need to do is for people to go in one, familiarize yourself with what is SHA, what is not SHA, what SHA can provide, what it can provide. And there are a lot of education platforms going on for this purpose, like what you guys are doing. So this is the right thing to do. Once people are familiarized themselves, people need to get talking. If tomorrow people begin to discuss, a thread starts on SHA, SHIF, within 2 days and people push out like 3 million tweets, even the government will pay attention. Unfortunately, I don't think our government knows how to mine information from what people are saying. I think they tend to want to muzzle the voices rather than hear what people are saying. So yes, I don't think we need to go back to the old system, but we need the primary healthcare fund, we need the SHIF, we need the emergency fund running. In fact, for me, the emergency fund should have been merged to the primary healthcare fund, because emergency care and primary healthcare are more or less one and the same. And then they should have left the chronic fund. But if you look at the chronic fund, there's a lot of overlap of what is supposed to be chronic and what is supposed to be ordinary disease. So there's still a lot of confusion, and I guess part of that is debates to go on with the health sector. But people need to go out, push hard, don't just learn, but push hard, push hard, push hard. And the way to push hard is push your MCA, push your governor, push your MP, and let people discuss this very openly so that tomorrow we will see better information. Because when Catholic bishops talk, people are bashing them. And I can tell you those Catholic bishops are not telling a lie. They run hospitals. And we have worked in some of those hospitals. When Christian Health Association of Kenya talks, people are saying, ho, ho, ho. Because you see, if money doesn't go to buy those things, there will not be service. When public health coffers, I mean, you go to a public hospital like the county I come from, and people tell you basically even accessing paracetamol is a problem. You get it. So people need to actually be able to shout and scream about the situation that is there. And finally, I will say, just keep your ID card safely enough for 2027. Because it's actually MPs and the Senate who are supposed to ring fence healthcare. Even as much as the executive is the one leading this because it's a big campaign issue for them, it is the MPs who allocate money. They are responsible for the rollout of SHA in a big way, and they are the ones who can ask questions on our behalf.
Thank you so much, Dr. Mailu. Thank you. Yeah, from what I'm gathering, for sure, we need to solve the political problem by making sure that we are ready for 2027.
No, we don't solve political problems. We just need to get slightly more empathetic politicians. Politicians are the same everywhere. There's nothing like sanitizing politics, by the way. It doesn't exist. What you have is if you push the politicians and they feel that they will not come back because now they haven't delivered, they will deliver for you.
Right. Yeah. Thank you for clarifying that. So yeah, so very important, and just being aware. Make sure inakuhusu. Don't ignore what is going on in the going on in terms of policy changes. All these things, in one way or another, they will affect you. Even if you're not sick right now, you don't need medical services right now. Someone in your family might need them. So inakuhusu, get to understand what is going on, understand the processes. If there is public participation, come out. Let your voice be heard. Very important to participate whenever there is public participation. I want also to recognize the presence of Sheila Chipkonga. She is one of also subject expert. We are out of time, but I would have loved to hear from her. She's been in our previous sessions discussing about healthcare, and we're hoping to also see her soon here in future. So, but again, I want to thank you, Dr. Mailu, for creating time to join us and to share these insights on about SHA. Thank you so much for your time. Dr. Mailu, again, is Executive Director for MEMA. Look MEMA up. They are doing a great job in the healthcare space. So we've come to the end of the session. I'm sure there are still many questions. As Dr. Mailu said, let's take these conversations online. You can visit our social media handles, Mwananchi Health Watch Initiative. let's continue talking. You have questions that haven't been answered. We don't promise all the answers, but we can try to point you to where to get some of those answers. So I'll give it back to Happiness. Asanteni sana for your time and have a wonderful weekend.
Thank you, Eric, for such a wonderful moderation. And thank you, Dr. Peter. Truly, you have enlightened us. I think we have so many take homes. And I also love the fact that you called us to action, like there is a part for us to play. So, for all of us, yeah, we were about 29 in this group. And now I see we are 22. I hope that we are going to take action. We will not be quiet. Yes. And thank you for those who have engaged us in the chats. It's really good to hear your feedback. I have seen Irene, I have seen Anthony. We truly appreciate you. Thank you for according time to just be here. We don't take it for granted. And now you are ambassadors. At least we understand SHA, SHIF. We are not as we came. Yes, Mercy, you're asking if there is a recording. We are going to put it up. We have recorded the conversation, so you will have it. As Eric has said, it's at Mwananchi Health Watch Initiative on social media and also our website, mwananchihealthwatch.org. So we are going to have that as well. So I will call maybe another volunteer to just close for us with a prayer. Feel free.
I can pray.
Thank you, Mercy.
And thank you, Mosoti and Happiness, for the good work you're doing. This might be the mercy you know. Let me pray. Lord, we thank you for the conversation that we have had. Thank you for speaking to the issues that we are grappling with. We pray, Lord, as we continue to contemplate on these issues and to think about how we can better engage, that you will help us and guide us. We pray for those that you have entrusted the governance of our country, that, Lord, you will be at work in their lives so that, Lord, even whenever they make these policies, they'll be led and guided of you, O God. We continue to entrust ourselves to your care, that you'll keep us in good health, you will keep our families in good health, even as we continue to grapple with these issues on a day-to-day basis. And Lord, even as you help us to engage better and participate in the platforms that are provided for us to give a voice to our leadership. We thank you and we honor you in Jesus' name. Amen.
Amen. Thank you
Amen,
so much,
amen.
Mercy. Yeah, thank you, Shayla. We see your comment. So, guys, feel free to leave. Tuonane.
Kwaheri.
Asanteni.
Kwaherini.